So this next case is Claire, and she's a 33-year-old patient looking predominantly for under-eye treatments. She's mainly concerned about the tear troughs, which she has successfully had treated before. But during consultation, we've identified a few other zones which may benefit Claire. And so let's run through a facial assessment systematically so I can show you what we're planning to treat.
Sorry to interrupt this video. Hi, I'm Dr. Tristan Mehta, founder and CEO of Harley Academy, and I'm the one doing the injection that you're watching right now. I just want to take a moment to talk about our injectables diploma. So Harley Academy is a higher education college for aesthetic medicine based out of the centre of London, UK. And over 3,000 medical professionals have gone through our academic programs to achieve a postgraduate diploma in aesthetics. They will get a title after their name, PG Dip Aesthetics. If you want to learn more about our programs, how you can gain your qualification and learn how to inject in a really structured, systematic and evidence-based way, then click on the details below and our team will be happy to have a conversation with you. Right, that's enough from me. Let's get back to the video. But if you are enjoying this and you want to see more content like this, please subscribe and click like.
So first of all, we notice Claire has very aesthetic features generally. I think she has beautiful symmetry, beautiful structure to her jawline, very clear skin. And if you notice from the side, the first thing that I can pick up here is she has quite angular features. And this means that she is a great candidate for filler treatments, as we can sort of accentuate these. It also means that it's a reasonably narrow margin, high stakes kind of treatment because she also has quite a tight skin envelope alongside these quite angular features. When we look in the upper face, we can notice that there is a little bit of a flattening to the frontal bone or the forehead. And so if we create some convexity in the forehead where we lose volume in quite these characteristic areas with aging, then what we can do is definitely soften and feminize the upper face. So I think a forehead treatment would be very good in Claire's case. As we go back to the center, we have very good eye symmetry, eyebrow symmetry. The eyebrows are sitting on top of, or over the top of the brows. I think with a little bit of neuromodulation would be really nice to try and lift the eyebrows a little bit. But that's separate to our filler treatment plan that we're looking at today. She has good volume in the temples. If we move to the midface, I think we've got well-defined cheekbones, but we were discussing about whether a little bit more lateralization here would be very aesthetic, especially in keeping with the strong definition of the jawline that we have here. I think some lateral definition along the zygoma would be very effective. As we approach the medial aspects of the midface, I notice a little bit of flattening here, which is very common as we start to lose some of the deeper volume in the cheek. And so if we're going to treat the under eyes, I would recommend some volume in the anterior cheek to support the under eye before direct treatment, and also treating the palpebromalar groove here with a cannula would be very good as well. The final area that we've identified to treat is the nose, and that's just to try and create a little bit more symmetry. And we notice here there's a little indentation to the left aspect of the dorsum of the nose. So again, a treatment with a cannula just to create a bit more definition would be a very effective way to reduce this small notch in the dorsum of the nose and also create an even more aesthetic profile to the face. So, in summary, this is a upper and mid-face filler treatment, and we're going to get started with the mid-face. So first of all, let's review some of the anatomy of the mid-face, because this is going to be relevant when we're teaching the tear trough and when we're treating the deep compartments of the mid-face. So let's start off with the bony orbit. If I mark on the bony orbit, the inferior bony orbital rim, this here is the origin of the orbicularis retaining ligament. This retaining ligament is all the way around the eye, And laterally, we have something called the lateral orbital thickening. There is another ligament that divides off the orbicularis retaining ligament, called the zygomatic cutaneous ligament, from the medial limbus of the iris down and inserting here at the zygomatic cutaneous ligament cheek apex. So between these two ligaments, we have a deep fat pad called the medial SOOF. And this is directly beneath the orbicularis oculi muscle. If we extend beyond the zygomatic ligament, this area, again underneath orbicularis oculi muscle, we find an area called the premaxillary space. The premaxillary space is a potential space that we can volumize in select cases just to create a little bit of structure when there's some anterior cheek flattening. In this case, I'm interested in creating some volume in the medial SOOF and the premaxillary space before then treating the tear trough and the palpebromalar groove. In addition, I want to create a little bit of projection and definition at the apex of the cheek, because I think this will be a very beautifying treatment. And we can identify this ideal point of the cheek apex by drawing a vertical line down from this bony orbit I can feel here, this lateral orbital rim. We draw a vertical line down. We can see as an intersection between this vertical line down and a line drawn from the alar base to the tragus, roughly where we would want to see a nice beautiful apex of the cheek, around here. This cheek apex can be addressed whilst we're treating the deep compartment of the SOOF and then moving on to the premaxillary space. So my first treatment before moving to the under eye directly is a cannula treatment that's going to target 3 different zones. Number 1, some volume to create projection at the cheek apex. Number 2, restore some volume in the suborbicularis oculi fat. Number 3, a tiny amount of volume in the premaxillary space to create anterior volume and additional support under the eye. Once I've completed these 3 treatments, I can then directly treat the under eye. So let's get started. The kind of product we want to use here is a projecting filler, but not the most projecting filler, because remember, when we're treating the anterior cheek, we want to avoid any idea of overfilling. And so we're going to be using Revanesse Contour with a 22 gauge cannula. I'm going to make my entry point. This same entry point is going to be used for all of my treatments in the midface and the tear trough. And I choose this entry point to be just underneath the apex of the cheek and enough distance for my cannula to travel where it needs to travel. So the first treatment, if you remember, is to create some volume at the cheek apex. And the cheek apex, underneath muscle, we feel a little push as I treat directly underneath the orbicularis oculi muscle. So this is the boundary between the medial and the lateral SOOF, and it's right at that intersection between the lateral orbit and the line connecting the base of the nose to the tragus. And I'm going to inject 0.15 mil here, just to create a little bit of definition where I think it will be extremely effective. Okay, it's as simple as that, 0.15 mils. And I'm just going to show you how this looks already, so we can start to appreciate the treatment as it unfolds. So sit forward, look into the camera. We're starting to see this beautiful definition start to emerge into the midface. Head back, please. Extending this treatment now, we're going to move into the medial SOOF, same depth, same anatomical target, just a little bit more medially as we continue to restore volume to layer 4 in the midface. As I reach this point, I have to move through the zygomatic cutaneous ligament and into the premaxillary space. So you'll feel a little push as it gives way. And here we have to be very, very careful not to add too much volume. So I'm going to be injecting 0.05 mils of filler. And that's all I wanted to do for the deep structure of the midface before we move on to the tear trough. To recap, the cheek apex, the medial SOOF, and the premaxillary space. Next, we can move to use a much softer product, Reveness Revise, and with that, we can move to treating the tear trough directly. I'm going to use the same entry point that I've just used for the deep cheek compartments to then move on to the under eye. When we treat the tear trough itself, we have to be very careful about the specific anatomy of the tear trough. And you will notice here that the subcutaneous fat pad of the nasolabial fold at its most cranial margin forms a groove here called the nasojugal groove. Okay, people confuse this with the tear trough. In actual fact, we're treating the gap between this line and the actual tear trough itself, which is higher up. This actual tear trough is this line here is the tear trough ligament, which is the medial aspect of the orbicularis retaining ligament. And so our volume is this very small gap between the ligament and the nasojugal groove. You will notice that the under eye hollowing extends more laterally and forms a groove here. And this groove is the palpebromalar groove, moving all the way laterally under the eye. And this forms when the subcutaneous fat displaces downwards with aging. And so I'm going to have to approach this from a lateral direction to restore the under eye in this component, whereas I can treat this one from the same entry point I've already made. So using a 22 gauge cannula again, we're in the subcutaneous fat here, and like before, we're going to push behind orbicularis oculi, and you see this dimple here as I push underneath layer 3. There. Now I'm in the suborbicularis oculi fat, and it's this same depth that I want to be in as I approach the under eye with my cannula. You will notice that the cannula becomes more superficial, but it's still under muscle in this depth. And when I look at the under eye from the side, I've almost created a complete transition from the lid to the cheek. And so volume is only helpful when there's still a gap or a deficit. If there's no more gap, then you should stop with your filler, or actually slightly undertreat by 20% in the under eyes, because we always have to leave some space for a natural swelling process when you inject hyaluronic acid. I'm going to add a touch more, and this time I'm going to demonstrate how we can just inject subdermally. We have to be very selective when we do this and very cautious, But if you feel like there is a tiny transition that can still be addressed by injecting into the subdermal plane, then we can. This is what it looks like when we're subdermally, with very, very small touches of volume. This is what I would call a cannula microbolus technique. In cases where we're confident there's low risk of edema, then this may be an effective way to get an even better transition from the lid to the cheek. To complete the infraorbital treatment, I'm going to move to the palpebromalar groove, and in this zone of the face, the orbicularis oculi, and in this zone of the face, the orbicularis retaining ligament splits into multiple ligaments laterally like this. And when we're injecting, we have to be aware that this intralaminar zone is where we're targeting with our hyaluronic acid filler. So we're treating the interlaminar fat, and we're going to be taking a lateral approach to try and restore volume here with a very soft product, Rejuvenate Revise here, to create a natural transition from the lid to the cheek laterally. I'm changing my cannula to a 25 gauge cannula because we're now treating a far more narrow target. So making an entry point overlying the zygomatic bone, facing medially, just through the skin. With the 25 gauge cannula, we're going to go through the skin. This is subdermal fat. Then we're going to move behind orbicularis oculi muscle. And now we can progress into layer 4 at the palpebromalar groove with the target of restoring volume at the intralaminar fat. Again, these injections are not sausages of hyaluronic acid. We're creating little micro droplets. The total volume with Rejuvenate Revise for the under eye here has been 0.4 mils. So let's take a look after we've treated the cheek and the tear trough together on the right side of the face. If you could just sit forward and look into the camera, or head forwards. Brilliant. So turn this way. Start to appreciate a little bit more structure and definition. Okay, so the next treatment we're going to demonstrate is a lateral zygoma treatment. Turn this way, please. What we're going to be treating is the deep plane in the lateral zygoma in order to create some deep, beautiful projection, to slightly lateralize the cheekbones, to create a more V-shaped feminine midface. So remember, when we're treating the lateral zygoma, we have two different depths. We have the subcutaneous plane, and then we have the pre-periosteal plane. I like to draw on the cheekbone So we can see the angle that the cheekbone is already traveling at. And this angle then determines where we want to create our direction of the product. And let's just quickly review the anatomy of this area. So remember, in the temple we have 10 different layers. Okay, so we have the skin, we have the subcutaneous fat, and we have the superficial temporal fascia. This superficial temporal fascia extends to become the SMAS of the midface and connects with the orbicularis oculi. So we have the superficial temporal fascia, which is a fascial plane we can be above or beneath for the zygoma. If we're treating above layer 3, we're in the subcutaneous plane. If we're treating beneath layer 3, we're in the deep fascial plane. It's worth mentioning that there is another fascial depth, which is layer 5 in the temple. Layer 5 is the superficial lamina of the deep temporal fascia, which also extends over the zygoma and across the midface to create an even deeper fascial depth. However, it's very difficult to differentiate between whether you're beneath layer 3 or beneath layer 5 when we're injecting the lateral zygoma. And so it's simplest to think about treating the zygoma either in the subcutaneous plane or beneath the deep fascia of the midface. And in this case, I'm going to show you how we treat deep with a cannula. So, using a 22 gauge cannula here, we're going to make a little entry point along the zygoma, facing laterally. And I'm using Revenes contour here, using about 0.2 mils per side. And the objective is to create as much lateral definition as we can. Remember, we've already treated the deep anterior cheek and the apex. So if we pass our cannula into the subcutaneous depth, what we want to see is another depth. So we can push against this little dimpling here, which is layer 3. There. And now we're treating in the deep plane of the lateral zygoma. And we can access all the way down along the cheekbone and start to gently create some definition. .25 mils, all that's required here. Let's take a look at what that looks like just with that small amount of lateral definition. Just going to sit you forward, head up again. I hope you can appreciate here the height that's created in the midface. Compared to this side, we have a lifted, beautiful cheekbone, and that is continuous all the way from the apex that we created all the way back. Head back. Let's demonstrate that on the other side again. Making our entry point just through the skin. And again marking on the cheekbone. Pushing into the subcutaneous depth first, and then deep through the orbicularis oculi, underneath layer 3, and now advancing and gently fanning in 0.25. creating the volume in the cheek apex, the medial SOOF and the premaxillary space, then treating the tear trough and the palpebromalar groove, before then creating lateral zygoma definition. And let's take a look in the camera. Now let's move on to the forehead. So if you lift your chin upwards for me, what we're going to identify is the areas of the forehead that have lost volume that we want to treat. And often they're in quite a characteristic pattern. If we follow the brow round, it's often this area above the brow, extending just to the temporal crest. We will often have an area of projection in the central forehead, and I find the best place to stand when you're marking up the forehead is at the top of the bed. And so this shape here is quite a characteristic shape that you will see when treating the forehead. Usually volume loss is in this pattern in most patients that we see. If you sit forwards for me, this is the area broadly where I see that there is volume loss. And I think the volume loss is a bit more above the brows and a bit less above the nose in the central forehead. And so my approach is going to be an entry point laterally, extending into the forehead, creating linear threads of product, ideally making all the way through to the midline. Bear in mind that the forehead is curved, and so a more flexible cannula is ideal when treating the forehead. At the same time, we have to be very careful about the blood vessels in the forehead because, as we know, the forehead is one of the highest risk zones in the face alongside the nose. And so the reason we have to be very careful is because of these blood vessels. So let's just briefly recap those blood vessels. We have the supraorbital and supratrochlear arteries, so supraorbital, supratrochlear, supratrochlear, supraorbital. These arteries are ascending the upper face, and they start off deep, and then when they move past the brow, they become superficial as they ascend through the layers and start to become in a more superficial plane. And so the appropriate depth when we're treating the forehead is deep. We want to be on the supraperiosteal plane, gliding with a cannula underneath the frontalis muscle. I like to use some lidocaine in the forehead because it can be a little bit scratchy. So we make some areas where we want to insert our cannula just onto the temporal crest, just medial to the temporal crest, so our entry needle can hit down onto bone. That will then allow us to find the right depth to progress into the forehead. Well done. Using my lidocaine, I'm also just going to generally create a little bit of comfort for our patient so that the cannula is less scratchy along the periosteum. So I'm going to be using a 22 gauge cannula, and I'm making my entry point now down onto the frontal bone. And I'm going to leave that there just for 10 seconds to make sure I haven't cannulated any vessels. And the product I'm going to use is Rejuvenate Ultra, something with medium projection, but definitely soft enough to be appropriate for this very narrow plane that I'm injecting. We're going to pass our cannula through the subcutaneous fat and through the frontalis muscle and its surrounding enveloping fascial layers, and we're going to be pushing underneath so that we're gliding onto periosteum. And when you're in the right depth, it will feel like it's gliding very smoothly. From here, with gentle anterograde pressure, we can restore volume in the areas that we've identified. Well done. How's it? How does it feel?
Fine.
Feels
A
fine.
bit numb.
Good. So this is the lidocaine really helping to make the injection more comfortable. Now this is where we find the curvature of the forehead can be a little bit of a challenge. And so how do we navigate a curved forehead with a straight cannula? We've got a few tricks up our sleeve, which I'm going to demonstrate just once I've finished restoring volume laterally. So it's around here where I feel like the cannula needs to curve. So what I'm going to do is I'm just going to help create a little bit of a shape to my cannula with my non-dominant hand so that we can start to arch the cannula slightly to help to navigate this direction. And from here now, I can more easily approach the midline. I always prefer to treat the forehead from the side rather than treating the central part of the forehead from the superior direction, because I feel like it's lower risk if we're perpendicular to these crucial vessels, the supraorbital and supratrochlear arteries. Everything in the upper face needs to be slow and controlled, low pressure, and ensuring we're in the right depth as we progress. Again, because of the curvature of the forehead, we can find that the cannula moves into the superficial planes, which is where we don't want to inject. So this is me having injected 0.6 of Rejuvenate Ultra into the forehead. Now crucially, what we don't want to do is leave a big thumbprint in the forehead after we've injected. So we just use our gauze to try and create as much smooth definition as possible. But I'm really happy with how we've managed to create some convexity across the forehead on this side. Turn this way. Now let's have a look if we can see anything. Sit forwards into the camera. Beautiful. If I turn this way, you can see here we have the same brow ridge. If we turn this way, we start to see it becoming more rounded, more feminine, more convex. Head back. Let's do the same on the other side. We've created a place for my pilot needle to go down to bone. And we leave that for a few seconds. I still have my curved cannula here, so this is going to be helpful for me as I'm approaching the forehead from this side. And then we push into the supraperiosteal plane of the forehead. When you're there, it should feel like you're gliding. Very little friction. Comfortable? Mm-hmm. Okay, great. Thank you very much. Brilliant. So that, now if I examine from the top, I can see a much more convex shape to the forehead. And often I would do a second treatment in a few weeks' time to try and fully restore the volume. But as always with these things, it's often to go slow. We don't need to do an entire 2 mils of filler in the forehead in one sitting. So sit forwards for us, let's have a look at the camera. Turn all the way this way. Starting to see now how much we can change the forehead with filler.